Please note that the content of this podcast is for general information only, and it is not intended as a substitute for professional medical advice or treatment.
Hi, everybody, and welcome to the DEARG podcast, the podcast that brings you education and information on endometriosis and adenomyosis. My name is Kathleen King, and tonight I'm joined by Jo Chapple, who is a chartered physiotherapist for over 20 years. And in her career so far, she's worked across not just the public, but private sectors as well in the UK and Ireland, and establishing and developing her own private practice in Ireland's real republic, Cork. She goes by Pilates Physiotherapy Cork, and one of her specialist areas is female pelvic health. And she's also passionate about pelvic health promotion and the accessibility of quality information for all. This is right up the DEARG podcast street, isn't it? So, Jo, welcome to the podcast. Do you want to tell us a little bit about yourself and how you came to specialise in female pelvic health?
Thank you for having me, Kathleen. It's a real pleasure to be here. So thanks for that. So I've been a physio for quite a while now. I started off just in musculoskeletal physio, so sort of more broad, whole body stuff. But in the last 10 years or so, it's sort of a bit more women's pelvic health, especially, and more by sort of accident by design, really. My own sort of personal experiences of infertility. I don't have endometriosis as far as I'm aware, but I have had sort of personal struggles with things like not being able to get pregnant myself, and that caused quite a lot of emotional pain and toll for me, and just sort of opened my eyes more to the world of pelvic health. And it has only been in more recent times that I have kind of stepped more consciously into the endometriosis and adenomyosis space. And I would say consciously because obviously, people present to physios and healthcare providers all the time, maybe with undiagnosed endometriosis and so on. And whilst I may well have worked with many, many people over the years with these diagnoses, I wouldn't necessarily say that we were always working with those specific diagnoses in mind. So it's only really in more recent times that I'm starting to kind of take a little bit more steps into the world of managing or helping people with these conditions.
Yeah, and I think we know that with endometriosis, we reckon that there's at least 1 in 9, but in some populations, we could be looking as low as 1 in 4, like as 1 in 5, depending on the population of people that you're looking
Absolutely.
at. So there's a huge amount of people out there that are undiagnosed.
Absolutely.
And as a community, we're very new to pelvic health physios, and certainly when it was mentioned to me, back, I think probably 2013, 2014 is probably when I sort of started to hear about it, and the fear went through me. It was like, oh no, there's nobody going poking there. This is going to make things worse. So in terms of what's going on with the pelvic floor, what are the dysfunctions that we would normally see with somebody with endometriosis or adenomyosis and that sort of chronic pain? Yeah. Is there something in particular that, is sort of common to all of those conditions?
There is loads of things. And I mean, I suppose if we're talking about very typical presentations with endometriosis, we have a lot of pelvic pain, whether that's sexual intercourse or any sort of penetration or intercourse, whether we're talking about pelvic pain, around the coccyx or pubis or any sort of pain in the pelvic area, really. But then we can also have dysfunctions with bladder and bowel. So that might be pain just trying to have a poo, pain with the bladder filling, pain, bladder emptying. There can be so many other bits and pieces in between as well. And so you have these typical presentations or these typical symptoms that people may have, and the pelvic floor it's not that it's obviously it's not the cause of any of these things, but it will be influenced quite heavily by all of these symptoms. Sometimes because of the pain of these conditions, the pelvic floor may be incredibly tense, tight, whether that's conscious or subconscious, when people are experiencing flare-ups, even if that is sort of with sort of menstrual cycle or not, because it doesn't always coincide at all, actually. And as everybody knows, so there can be lots and lots of typical symptoms. The pelvic floor can respond in very typical ways, which can be tension, tightness, but it's not always the case that that's the problem either. And we need to be really careful of not just looking at the condition and then stepping through certain protocols for treatment. So whilst there may be very typical things going on, whilst there may be obstruction with trying to have a poo because of the pain and the tension, whilst there may be significant bloating and significant pain, and why there may be pain with sex and all of these things, I feel we perhaps need to step back and first of all look at the person in front and talk and assess and listen and just understand first what is going on for them, rather than just going straight into assess pelvic floor mode. That doesn't ever feel like the right sort of place to start or the right fit. We need to look at the person first.
Absolutely. And it's such an individual disease. You could have, 10 patients in the morning and all presented with very different outcomes as well. And in terms of that initial assessment, so obviously that consultation is going to be very important. You're going to have a conversation with us. You're going to look and see how it's affecting us as an individual. What else could we expect maybe at an initial appointment like that?
Well, before I don't know about absolutely everybody else, but before I see anybody, I will always send out a ton of forms. And it's almost a bit of a joke before the person comes in. They feel like they've completed a dissertation before they come to see me. But there's a lot of things in those forms, a lot of general medical history, a lot of pelvic specific history, a lot of bowel, bladder, sexual function, menstrual history stuff. There's a lot of tell me about you, tell me about your goals, tell me about what you like, what do you do, what sports, activities, hobbies, interests you're involved in, and then sort of outcome measures and bits and pieces. So there's a lot of that before I see anybody, which I appreciate for some people might be a barrier. But interestingly, when people come in, quite often people are saying, do you know what, it's actually really nice to go through it all, put it all out there first, and to sort of get my own head around my own story and situation experiences, and also have somebody in front of you that you meet for the first time who's a little bit more informed, and you can almost sort of hit the ground running to some extent with people, is my rationale anyway. But then the assessment when people are coming in, what we're doing when you're meeting somebody for the first time, again, it's going to very much depend on what the person in front of me is looking for. Nothing will happen or should happen without full, complete, informed discussion and complete consent. And just because I may be a pelvic health physio, it doesn't mean that people are going to necessarily be taking any clothes off. I might not touch people for the first 1 or 2 or 3 sessions, or I might not touch some people at all because it's just not appropriate. And it's all very much guided by the individual. And I suppose the other thing that sort of come to mind as well is, okay, whilst I may be a pelvic health physio, and whilst we may be dealing with conditions that primarily influence pelvic function, yourself, with things like endometriosis, we might be dealing with other symptoms that are outside of the pelvis as well. And being able to sort of step back, being able to kind of look at the whole person, being able to fully understand what is going on for them, we can see what else we may need to look at and bring to the table as well. Because we may have some random left of centre symptoms to consider as well.
Yeah. And that's again, we're back to that individual assessment again, aren't we? That, I think as people living with endometriosis, we tend to compartmentalize our pain. We're like, oh, that's our endo pain. Don't worry about your back that you've completely knackered because you've been standing all crooked, or you've been standing on one leg for most of your life, to balance yourself. Yeah. So it's good to see that there's that sort of, bigger picture as well too, and looking at everything else that's going around. Right. So in terms of pelvic floor physio, how could we, use it to sort of help maybe manage pain or other symptoms? Like, we know that we're prescribed maybe a, physio, musculoskeletal physio, like if we've had a broken arm or broken leg, or we've had an injury, is it very, very much the same for the pelvic floor, or is it a little bit more complex than that?
I wouldn't necessarily say that it's complex, but I would say that I don't think it's complex. There's just different. I think with physios, all physios, regardless of whether we specialise in pelvic health or not, there's a few sort of areas that we should cover, and we do cover. And that isn't just traditional physiotherapy, what we might do with our hands, what we might do with touching the patient in terms of manual therapy, or any other skills we might have, whether that's things like dry needling or acupuncture training or whatever it might be. There's lots of other things that we really should be fulfilling as a profession, and lots of us are doing, which is things like, how might we help somebody with their own self-directed care and their own hands-on and their own self-management of, that hip that keeps on flaring up, or the back pain, or, their dyspareunia or vaginismus, or whatever it may be. So there's the traditional physio road, hands-on work that can be really beneficial if it's consented and explained and all of that. Then you've got, how can we help to empower the individual to do their own bits and pieces for themselves as well. And there's a lot we can talk about with all of that. Then there's also, how else can we bring other people into the team, if you like, whether that's their partner, or whether that's a trusted family member, or a friend, or whatever. Because, when we're dealing with things like endo or adeno, and things that aren't unfortunately quickly fixed, we need as many strategies as we can. And sometimes that's roping in other people, if that's something that the individual wants to do. So, often there may be other people in the treatment room with me, not just the client, and that's all good. That's great. But then there's tons and tons of general information that everybody needs to know as well. And sometimes when I work with some people, because as you've said about, there's a lot of fear, there's a lot of, I think this is my impression, distrust as well, because people have not always been treated optimally. Sometimes I'm just talking with people. Sometimes sessions are just information sessions for people, and then people might go away and chew the cud, and then maybe they might drop in every now and then for a bit more stuff if it's appropriate for them. But I'm digressing. But physios, we need to be covering, the very general information that people need to know about, like what is optimal pelvic health, what is optimal bowel health, how do we have a poo when we've got tons of pain? What do we do if your bladder is hurting every time it's filling up? Like, basic pelvic health advice and information that people need to know, but also typical physiology, what about pain? How does our body respond? How can we strategize, and how can we manage? So, hands-on physio stuff, yes. Self-directed stuff is important. Getting other people involved, partners, friends, whatever. General advice and information. And then just lots and lots and lots of strategies about how are we going to help to manage pain? What are we going to do? What are we going to do when you are having an incredibly acute episode? What are we going to do when that eventually passes and you're back to your day to day? What are you going to do on good days? What are we going to do on bad days? What are we going to pull into the mix here? And sometimes some things work and sometimes some things don't work. And there doesn't seem to be a set rhyme or reason, and it doesn't seem to be that we can give a formula to people. And sometimes some things work sometimes for some people, and something that may not have worked 2 years ago, maybe we try again. And so there can be lots of coaching from the sidelines as well. And trying to problem solve and strategize and look at what else we can do, even if it seems random, strange, useless, futile. Sometimes it's those weird things that can make a difference.
And I think, Jo, just what you were saying there to me really strikes as important is not just the individual approach, but that team approach as well. And, pelvic physios, we feel, should be a really important part of the pre and post-op journey. And certainly from my own experience and that of other women that I have spoken to, is that, it becomes a tool for life, and it becomes something that you take those skills with you and apply them at different times. And I like the way you mentioned there that, you need to have a plan for days that you're in flare. And you would need to have a plan for days that, you're maybe feeling stronger and a little bit better. And do you find that, people could maybe use pelvic physio on its own as a sufficient treatment, or does it work well with other treatments? So say like hormonal suppression or somebody who has had surgery, do you find that there's an overlap there?
Yeah, I think that's a brilliant question, because I think not just with sort of pelvic health or endo or adeno, but once upon a time, and I'm talking sort of back in the day when I qualified a while ago, you'd have this sort of idea of, if you're having physiotherapy, you can't do anything else, because we need to see exactly what outcomes we're going to have. We need to see how effective we're being. And yes, I understand that. And yes, that makes sense in a laboratory controlled environment. From a day-to-day, real life, ethical perspective, that doesn't make any kind of sense to me at all. When someone's quality of life is not just low, but has disappeared, I have been in situations where I've struggled with certain things, like my fertility journey, and I would have done 10 different things to make a difference. And that, I think, is normal, natural human behavior. You want to do everything and anything you can. And so physiotherapy, in my opinion, really should be able to run alongside what else might work, or what else might complement, or what else might help. If we can help people live with better quality of lives, we should be helping people live with a better quality of life, and not Absolutely. Sitting in our ivory towers and
Absolutely, because we would all love to have the perfect research clients that we can sort of write a paper on, and they've started from start to finish, but things aren't linear, things aren't like that. And you'll hear me chatting on about this 1% theory of mine, that every little piece adds up. So I love seeing people mixing and matching treatments. I love them taking something like acupuncture, maybe combining it then with their surgery, combining it with the pelvic physio.
Absolutely.
So many things.
Absolutely. Absolutely.
And I think we have to be led as well by the individual patient, and by their sort of wants and needs. And as you've rightly said, that can change from day to day, week to week. And certainly that period of time, in terms of, you're saying there, about appointments and about, trying to manage, I suppose, expectations as well too. Do you find that your sessions, are you leading the sessions more, or is it led more by the patient? So if the patient said to you, look, Jo, I can't handle this week, do you find that you sort of have to say to them, look, okay, we'll do a little bit or whatever, or what? How does that work with you?
No, it is very much, at least the way that I approach it. And I think I've got a lot of experience with what we call the biopsychosocial model of care as well, where we're sort of looking at the whole person and everything all together. We're not just focusing on an organ, or that's a simplistic term, but we do need to, I often will say to people that, I'm in the front seat of the car with you, but you're the one driving the car, and if somebody is in front of me, or on the phone, or over email, saying to me, today it just cannot happen, or this week it cannot be, then I'm going to believe that and trust that and go with that, because nobody knows their body better than the person who's living with their symptoms. And if their pain is at such a point that they just know they cannot tolerate anything, and I mean, there's times when people are saying they can't even wear clothes, they can't even get through the next hour, let alone the thought of getting in a car to go to, so if somebody is saying to me that this can't happen, they don't need to explain it or justify it to me. We just need to listen and understand and strategize. And it's like, okay, so what can happen? What do you want? Where do we go? And I think that's the way to play it, because our role is to facilitate.
And that's where the plan comes in, isn't it? Because if you have a day where you just can't face getting into the shower, putting the underwear on, or even getting down the stairs, that's where the plan comes in. Because tomorrow could be a different day to really start something again.
Yeah.
And could you give us maybe an example of some techniques that you might use, like with patients, especially those like with sort of pelvic pain?
Yeah, well, again, it's going to depend on what is the main goal for that session or for that person. And sometimes if somebody is coming in, they want to look at building up their good day strategies. They want to be able to kind of get back into some sort of meaningful exercise activity or any sort of meaningful task. So it's all going to depend on what is individual and important to the person. But it might be that we're looking at, if we're talking about pelvic floor type stuff, if they want to be able to try and, I don't know, get through a yoga class or a gym session or something like that with less discomfort in a movement, then we might be looking at, okay, how are we doing that movement? What is happening? How are you breathing? What's going on with the tensions in your body? So I might be looking at sort of how that exercise is executed. Might be sort of, if it's okay, having a feel of the body, maybe looking at even doing pelvic examination, maybe even doing vaginal examination as someone is trying to do something. Are they able to breathe? Are they able to relax? Are they holding tension? Do we need to work on releasing some tension somewhere? Do we need to do some stretches or manual therapy, hands-on work? But it might be that somebody wants to look at trying to help for pain management. Maybe we need to explore sort of pressure point work. Maybe we need to look at exploring how they're going to use a TENS machine. Maybe somebody might find that, I'm thinking of one person who, they were in a bad flare up, there was a lot going on, and a bit of kinesio tape made a difference. And it wasn't any sort of taping technique that's in a book. Oh God, I'm not sure what's happened there. Sorry. Something's just occurred. something happened. So you're kind of improvising this stuff, and so it might be that I'm taping something somehow for someone in a certain way that might feel good, and if it feels good, then we're going to talk through how they're going to do that again. And so what we might actually do, or what I might actually do, is very broad. It's very variable. It's going to depend. What is a specific goal? There are lots of standard physical and physiotherapy interventions that we can do, but there's no standard day, there's no standard case, there's no standard person, there's no standard endometriosis. And I think what that I think is important to say is that we're not actually treating the condition, we're not curing, we're not in that position where that can happen, certainly from physiotherapy, even beyond that moment. Not everybody has got access to optimal care in the way that we want. So physiotherapy is looking to help modulate in any sort of way that we can. And I think a touch of creativity and a broad lens is really important in that.
And it's pulling in all the tools, like out of the toolbox, really, isn't it? And
absolutely.
Like the kinesiology tape is fantastic. The TENS machine is my go-to. I've been using the TENS machine for probably, I it must be 25 plus years at this stage. I absolutely love it. I know some people hate them, so it is. It's really
again,
isn't it?
Absolutely, it's finding what is going to work for you and being open to that, and absolutely.
Yeah. And in terms of, like techniques used in physiotherapy, are heat and cold used in any of the treatments at all? Or?
Absolutely. Yeah. I don't tend to do them in my sessions with people. I will talk very much about it because, there's that we can do things to people. There's lots of sort of passive types of treatment, which I think have a role. Absolutely. But I think there's so much more that we can do as well. I wouldn't necessarily have people coming to me and I'm using a heat pack on them. But that doesn't mean that other people won't or can't or shouldn't. I think there's a lot to talk about in terms of, the benefit of using heat, but also we need to be mindful, because people can sort of really damage their skin with prolonged use if they're not careful. We need to kind of think, what else might we do? How else are we going to manage here? What other strategies can we use? But things like ice as well, and even just sort of in terms of acute pain flares and distraction techniques and management, just even sort of holding onto some ice cubes or rubbing a different part of your body with ice, sort of distraction techniques and strategies, and those kind of things. Like I would call those kind of basic passive things are really helpful and really important. There's nothing that we shouldn't look at, really.
That's good. I like that approach. And in terms of, say, if you have like trigger points, and we talked about you could have pains in other parts of your body, but if you've like, say, trigger points from referred pain, is it safe to work on those if you think maybe like, that there's a tight knot in the hip or in the leg or, in one of the glute muscles? Is it safe to work on those knowing that there may be some endometriosis in the pelvis that's feeding into that nerve or causing that spasm? How would you know to sort of work on that or not work on that? Or is that very individual again?
Again, it is quite individual, but as a general rule, and one thing that I think is quite nice about physio is we can't really do much damage, really. Now, that doesn't necessarily mean we can't cause pain. We shouldn't be causing pain. We don't want to be causing pain. We want to be helping people to move forward, to optimize their general health, their well-being. We want to reduce pain. We want to generally increase comfort and functionality. But physiotherapy, in my perspective, is relatively low-risk intervention. There are things that we can do that can not be optimal and ideal. But I think one of the bigger things that can happen is we can cause pain if we are too heavy-handed, if we are not listening, if we are not understanding what someone is telling us, and if someone has a tight pelvic floor, for example, for whatever reason, and we sort of we're going in, we're going to release these trigger points, we're going to it's not necessarily conducive to optimal outcomes or helping people feel better. So, the patient physiotherapeutic relationship has really that's got to be solid, or at least there's got to be that kind of respect and trust there. There's got to be that sort of team approach. And so in terms of, is it safe to do things to muscles that may be tense and tight, even if there is endometriosis in and around on the nerves and so on? My gut response is generally it's safe to do most of the interventions that we can do. It's more about, does the person feel safe? Does the person feel comfortable? Does the person feel confident to do it? Does the person understand why it might be helpful? Does the person understand what they may need to watch out for? We spoke about, heat. Yeah, brilliant. It's fantastic, but not if it's causing skin damage, long-term use, and so we've got to look at the pros and cons with everything. That's a discussion. That's, and then the person gets to decide.
Yeah.
So is it safe? General terms, yeah, it is. But Is it what that person needs to do or wants to do or should do? Well, that's a different thing.
And it's back to the informed consent and that open
Absolutely.
communication, isn't it? And I think
Absolutely.
that's always a hard thing to find as a healthcare professional, no matter what realm they're in, that you can actually have that open conversation with. I should be able to say to you, Jo, what we done last week absolutely flared up crazy. We may not do that again this week.
Yes.
Can you give me an alternative that we could try? Or maybe we won't try it, maybe for a week or two to see how it goes.
Absolutely.
Certainly, I know myself, I'm very guilty of it. If a treatment didn't work or whatever, sometimes you'd sit there quietly and you'd be like, oh, I'll just put up with it. Well, it has to be doing good. And we condition ourselves to give feedback, don't we? We have to be
absolutely
very open and honest about our pain and our experiences as well too, because certainly once you explain and give that feedback, I think your therapist, can adjust your treatments around that, make things a little bit more comfortable as well.
That is massively important, and I don't think that is all on the person with endometriosis. That's very much, there's a massive responsibility on the therapist to read the verbal and non-verbal signs there. And, there can be a split second of a hesitation. How did you get on last week? How did you find this? And that split second can say it all. Because if there's been a generally positive response, if something has made a difference, there's a hope, there's an excitement, there's an optimism, there's a joy, there's a smile, do you know what? And when it's the opposite, there's that pause, and we must be cognizant, we must be mindful of that. We, as the kind of practitioner, we've got a duty of care there as well. And if we suspect that, okay, maybe this person doesn't want to give me honest feedback, maybe they're afraid of how I'm going to take it, and I can understand that, but there's no place for that. There's no place for that in a healthcare setting. It's not about the therapist. It's the individual. So there's definitely, in my opinion, a responsibility on me when somebody is coming in and you're getting the sense that all is not well, the last session was not okay, and that's for me to also try and help. Navigate.
It is, and it's that it's that partnership as well too. And I always say to people that they need to think of themselves as like head of a team or head of
absolutely
business, and you're hiring people in, and equally that has to be that two-way conversation, and you have to trust on both sides. And I think that is important.
And I think sorry.
No, go ahead.
I was just going to say that we do, physios and other healthcare professionals, we need to be looking at our figures and auditing our own bits and pieces as well, because are people not coming back because they're better? Are people not coming back because they're not comfortable to give honest feedback? Are people coming back because nothing worked for them? And there's an element of sometimes it's absolutely no one's fault, and it's the nature of the condition and the nature of the beast that we're dealing with, and now is just not the right time. Sometimes there's too many other things going on for the individual. This is not the right time to kind of dedicate physio time to. And then sometimes there are, unfortunately, just really hard discussions to be had if things are deteriorating, if we are having more bad days than good days, if we are not able to make a difference, and that's not through a lack of trying on anyone's part, then that's when maybe a threshold has been reached, and we need to have those discussions about, well, where next? And that's really tough, because currently we don't have lots of options. And if people don't have the finances, if people don't have the flexibility, then that's a tough conversation.
This is it, and this is where you can hit the wall with endometriosis treatments quite hard. And I've seen people go from being very happy and maybe working away fine, like with a combination of treatments, maybe their hormonal suppression, their post-op, or they're doing all the things right, and there is no right and wrong with endometriosis. If it's going to flare up, it's going to flare up, and
absolutely
nothing you could do to sort of prevent that. But sometimes that can be very hard, hard stop in somebody's life as well. And I think a lot of things that come into that, there's a lot of guilt and a lot of shame. And people think that they've failed maybe at a particular treatment. Or like, oh, look, I tried my best, but it didn't work. And it's changing our mindset around that as well, I think is very important, isn't it?
Absolutely. Because I think if we look at other conditions, and this again is just my own personal opinion, but if we look at something like cancer, there appears to be a sort of a different mindset. People don't, if someone with cancer is saying they're in pain, they're believed straight away. And there's okay, right, so we need to look at this, we need to up the meds, we need to, and that's not always the situation for a lot of people with endometriosis and adenomyosis, and that's not okay. And there's, if somebody with endo comes in and they're kind of saying to me, yeah, my pelvic symptoms are worse, my bladder, my bowel symptoms are worse, and so is my shoulder and my neck, I'm going to believe that the shoulder and the neck is worse as well, and what we're going to do to deal with that if we can, and how can we help it. And so, we can give all the information about pain management and how somebody might be able to work and self-manage, and what the partner can do to help. And we may have tried all things with physio. What we can't do is sort of almost get people to meditate their pain away and make people feel bad because they haven't done that enough and they've not chanted their mantras enough. And,
there is that huge pressure. And I think the terminology around a lot of chronic illness and even with cancer as well is not helpful. You're seen to have lost your battle with something, or you seem to have failed whenever your treatment has failed. And it's never that. It's never that straightforward. We're very complex organisms.
Yeah,
it's never just
absolutely.
One thing, is it? Like,
no, and that's across the board with so many other things, isn't it? Like you said that, and what came to my head straight away is sort of labour and giving birth and failed to progress. Did they fail to progress? And it's just absolutely, words really do matter. Our language matters, and very much.
One that sticks out in the obs and gynae one is always, it gets to be, it's like incompetent cervix, and you're like,
Yep.
Okay, we don't really call
it
prostate incompetent when it's not able to hold in urine, but
exactly. Yes,
words do matter, and they do have a huge impact on patients as well.
Absolutely.
And Jo, tell me, if you had a patient who's been with you, and we have very limited resources in Ireland for endometriosis in general, but specifically around excision surgery. Are you able to refer people to another healthcare professional, say like a surgeon, or do you refer people back to their GP if you find that we're at a point that this person needs a bigger intervention?
Yeah, so again, that conversation there's a conversation to be had about that conversation. What is your GP like? What avenues have you gone down already? Who have you been referred to already? There's a lot of people who I see who may have been referred to sort of gastroenterologists, who may have been referred to, different bowel specialists and so on, and they're coming to you to sort of have constipation addressed, and they've not been sent to a gynecologist. Endometriosis may not have even been considered. And I'm not suggesting that every bowel problem is, but when a history is taken, and when there's menstrual issues, when there's pelvic pain, when there's painful intercourse, when there's other things as well, and it's not responding to the typical kind of interventions, then we've got to think bigger and broader. So, I've gone off on different tangents there. Sorry.
It's okay.
There's so many things I wanted to say, but what was your particular question there, Kathleen?
Referring back to different health professionals.
I'm so sorry. Yes.
Okay.
So what I've done historically is, what's the patient's relationship with their GP like? Yeah. Because if it's a good relationship, then if I've got their permission, if I've got their consent, then I'll be liaising directly with the GP. Sometimes there's issues with that relationship between the GP and the patient as well. And then we have to look at, okay, how else might we navigate this? How might we access gynecological care? How else might we access other things? And that's quite frustrating and challenging at times because we don't have all the pathways there yet. But we really want, I mean, a multidisciplinary team on your doorstep would just be amazing.
Wouldn't it be a game changer? And you know, like all healthcare professionals and all therapists, I suppose, as well. And you know, I'll extend this out to you know, hairdressers and beauty therapists as well. When we're in an appointment, I think as women in particular, we tend to disclose things. So I might have came to you for a shoulder pain, and then by the end of the conversation, we'll probably have got around to chatting about why my coccyx is quite sore, like twice a month, you know. And
absolutely,
that's how we recognize endometriosis in people. And I speak to so many people, and they'll sort of say, you know, oh, endometriosis, I've never heard of that. And then I'll sort of go, oh, well, this is this. And then they're like, hang on a minute. I get really extreme fatigue and I would get migraines, but you know, the only real symptoms I would have is like I was, you know, pain, like, you know what I mean, when I pee, and you know, well, maybe like, and it's funny, isn't it, that signposting it's not there yet, and that's again, so that's a public health awareness campaign, I think, at this stage, isn't it, that not only do we need individuals to recognize within themselves, but we also need the healthcare professionals and the wider community to be able to recognize that.
I was just about to say that lack of awareness is not just general population level. It's all the way through, unfortunately, and that's a big challenge. Yeah,
it is a big challenge. Something that's going to take, I think, a huge amount of work, and it's going to take a huge amount of drive, not just from the advocates within this country as well, but their healthcare professional colleagues as well.
Absolutely.
I think we need everybody on board on this, you know.
Absolutely.
So just thinking back again, like, so if I've been to my GP and I've been to my gynecologist and I've done all the bits and I'm saying, okay, I want to give pelvic physio a try, do I need to have any x-rays or any MRIs or any scans or anything done before I would see you?
I would say no, because I think there's a lot that we can do, even just with the information that the individual person can give us. There are things that can be helpful. There are certain investigations and different bits and pieces and reports that if anyone has, I will very gladly take it all in. I will look at it all. But I don't think that a lack of those things or a lack of investigation should stop you from seeking pelvic physio, for example. Quite a lot of the time, certainly in private practice, not so much in the public system there, but in private practice, I would find that I might be one of the first healthcare professionals that people may be coming to talk about these issues and symptoms, even if some people have been living with them for years and years and years. So, no, I don't think it is essential at all. It certainly shouldn't be a barrier. If anyone has got reports, if anyone has had bits and pieces done, I will gladly take all the information in. But we need to be careful as well that we're not relying on the results of some things either, because we might have a report or an ultrasound scan or an MRI that looks fine or looks fairly unremarkable, or it may even show mild disease or issues. But that doesn't mean that the person in front of me is saying that their pain is mild or that their quality of life has only been mildly affected. So whilst it's helpful to have some information, and I will always look at the information, it certainly shouldn't be a barrier to stopping anyone getting treatment. And it also needs to be handled with care because it's not the full story.
No, very much. And I suppose just to use it as the tool that it is, it's an assistance to diagnosis as opposed to being a diagnosis itself. And
absolutely,
I see that get lost so many times. I see it get lost with lab results as well too. Like, you know, if the number's out, that's what's wrong.
Absolutely.
Never the case. So do tell me if there is any homework that we would be taking home from you. Would you send me home with a big long list of things that I have to do for the following week?
It's going to depend, and it's going to depend on what the individual wants. It's if you met me 20 years ago when I first started, I was longer than that now actually. I was very, very enthusiastic, and I could have sent people away with 10 to 15 different things to do. That was enthusiastic and overkill. And, you know, if somebody has just had young kids, if somebody is looking after an older parent who's unwell, if somebody is moving house, building a house, if somebody is out of work and trying to look for jobs, if somebody is going through a divorce, if somebody has got all of those things going on, maybe just having the assessment and somebody talking and somebody just kind of saying, okay, I'll be on your team. Maybe that is all that needs to happen. Yep. So I am always looking at ways that we can try and move things forward in as many different ways as possible. And I am a massive advocate, enthusiastic person about sports and exercise and activities. But that doesn't mean that that's going to be your homework. Maybe the homework is just get yourself a footstool so that you can actually put your feet up on a footstool when you're going to have a poo. Sometimes the homework can be just make sure your freezer's full of ice cubes. You know, sometimes the homework is going to be how are we going to do stretches to help relax or help to mobilize the hips, the lower back and the pelvis and the pelvic floor a little bit more. Sometimes it will be how are we going to do a HIIT session to get your cardio, get your heart rate up to a certain level, which might be helpful for pain management. And, you know, the homework can be so many different things. But what's really important, or what I try and make sure happens all the time, is I'm asking what the client wants, checking in with what I'm suggesting and making sure that that's what they want, making sure that it seems achievable, appropriate, realistic. Because if it's none of those things, it's not going to happen. And that, again, is human nature. So it's got to be tailored. It's got to be specific. It's got to be individualized. And it's got to seem of value. If I'm asking someone to do handstands 3 times a week, there's got to be a very good reason why. I don't ever give that as homework. I don't even know why that popped into my head, but it's got to make sense. It's got to fit. It's got to be achievable. It's got to be realistic.
That's it. And it has to be that sort of that bite-sized bit in the beginning, isn't it? That you sort of think, okay, how do I get to this point, you know? And on the topic of exercise and that is there anything that somebody with, say, endometriosis or adenomyosis and that sort of pelvic floor dysfunction, is there anything that they really should avoid? So should we avoid something like, you know, say Pilates that focuses quite on the core, or maybe some lifting or things like that? Is there anything that we really shouldn't do?
I'm going to say, as a very general rule, no, but it really depends on how. And this is part of the information that I think we as physios need to be kind of imparting and discussing, and the conversations we need to be having. Movement as a general rule is always going to be a good thing. Doesn't mean that actually somebody is going to be able to do it, because the pain flare may be so acute that nothing is happening that day, that week. And that's as it is, that's okay. But as a general rule, movement activity is going to be better than none. But again, it's got to be targeted, it's got to be strategic, it's got to be appropriate, it's got to be paced, it's got to be progressed accordingly. And sometimes people just love Pilates or love yoga or love whatever, and maybe we just need to kind of vaccinate them against some of the common things they might hear. You know, in Pilates classes might be activate your core, engage your pelvic floor, zip up your abdomen, draw in, and all of this stuff, which I'm not sure that we should be using at all, actually. However, that may be the narrative in some sessions. So that's our role as a physios to kind of say, look, when you hear those cues, what about reframing them? What about anytime someone says squeeze your pelvic floors, activate your core, what about if that's your cue to make sure you're breathing really deeply, to make sure you're really letting go, to make sure you're really relaxed? Maybe we'll use that cue for something completely different, you know? So maybe we need to kind of take that approach. So it's not necessarily avoiding stuff, but rather looking at how we do stuff. And as for things like lifting, strength training, weight training, resistance training, there are so many benefits to that kind of work that is bigger than just endometriosis, sort of for our own well-being, our own longevity, our own quality of life. There is so much benefit to being active.
Yeah.
But again, we have to balance that advice and that information when somebody is living with a condition that is so considerably painful and all-consuming. We have to be more helpful than just saying, well, you should be doing this amount of stuff because the World Health Organization says it.
Yeah.
That's a really unhelpful thing and strategy to take. We need to look at how are we going to help somebody achieve these things. But again, even if someone has had to undergo things like hysterectomy or any other sort of surgical procedures, it doesn't necessarily mean that getting back into the gym is going to be off the table forever. But we need to look at how we navigate that person back to that path.
Yeah.
And so again, it's very targeted information, it's very tailored information, it's very strategic, it's constantly checking in, it may be adapted. But again, it's trying to do that in a way that helps to empower the individual, not create fear, and also not create a massive reliance. You can't go forwards unless you check in with me. That's not the meaning. It's giving people the skills to know what to do if they're feeling better, if they're feeling worse, if they feel exactly the same. How are they going to strategize?
Yeah.
And then I think making sure that we're always available for people as well, just to give us that phone call, send in that email, check their questions, make sure they're on the right path. So I don't think any exercise or activity should be off the table.
Mm-hmm.
But it's going to very much depend. Is the person able? Is it what they want to do? Is it important to them? Mm-hmm. And then if it is, how are we going to do it?
And it's finding something that you like and something that you'll enjoy as well too, because it
Absolutely
doesn't need to be torture.
It shouldn't be. It shouldn't be. No one's going to keep signing up for something that they hate, that hurts, that they loathe. That's not clever.
That's the thing. And, I've spoken to people who've done massive HIIT sessions and they do it for the endorphin buzz because they're like, that's my pain down for a number of hours. I'm going to go for it.
Absolutely.
I might flare the day afterwards, but I'm going to go for it, and everybody manages that differently. But I think movement and strength and everything is so important because, we've been, predominantly given a huge amount of hormonal treatments. We may have bone density issues later in life. We could go into
absolutely.
So many things in women's health, isn't there? That again, we could sort of probably chat for another hour, on all the complexities of that. And I suppose my final question for you is around, one of the symptoms of endometriosis in particular, and sometimes with adenomyosis as well, and that's around, painful sex and the approach to that. And again, for some people, it may be that, there's a vaginismus there as well, or there's other issues. Do you find that, this is something that pelvic physio can be used in? And, certainly the feedback we've got is that it can be very long and slow treatment. And would that be your experience?
Yes, as a general rule. It is not usually the case that 1 or 2 sessions and you're fixed and sorted and off skipping into the horizon. And a lot of the time with a lot of pelvic health stuff, it can be variable for lots of different reasons because we are biological. We are not machines, and various other things can influence us. If we're under a lot of stress or under a lot of pressure, if we're unwell with other things, that can influence our pain threshold and how things change. And so with something like painful sex, if we focus just on that, we are still going to have a conversation about lifestyle. We're still going to have a conversation about the importance of maintaining your self-care, not when you reach crisis point, but generally, how are you looking after yourself all the time? What little things are you doing each day? What are the steps? What is nutrition like? What is your sleep like? What is your support network like? What are your stress management strategies like? Because we know that with any kind of pain, when our self-care is in our boots, our threshold for pain is also going to drop. And so we need to look at the whole person, even if we're talking about something as specific as pain with sex. And yeah, it generally is quite a slow process. I find generally we do want other people involved in the team there, whether that is sort of counsellors, psychologists. That can be quite helpful as well. But again, it's the same sort of principles. We want to be talking about what can the individual do for themselves, what can the physio do for you, what can physio do for you, what might your partner be able to assist with, what are the pain management strategies on good days, what are the pain strategies on the bad days. So it's a very similar sort of principle and approach. Physio may be actual manual techniques, may be actually getting into and around the pelvic floor. It may be looking at how we help to reduce tension in the pelvic floor. But that can be achieved in other ways as well. Maybe that is breathing strategies. Maybe that is looking at how we are going to be going to the toilet, how we're going to be opening our bowels, how we're going to be managing and avoiding constipation, or trying to help with any bloating, or how we're going to help to optimize your bladder health. So all of those systems to try and help reduce pressure or pain or the winding up of our overall pain for, painful sex. So there's a lot of things. Sometimes it may not, as I said, it may not even be actually getting anybody to undress. Sometimes it may not even be touching anybody for a long time. Sometimes it may just be talking about how we might treat. Sometimes it may be even like a graded exposure type thing. Talking about the treatment, getting the person to sort of even just touch themselves, trying to desensitize, trying to calm down, trying to help stimulate parasympathetic response rather than the fight and flight. There's lots of different ways we need to approach. And if we are just going to literally ask somebody to lay down on the couch, just let us do our treatment and trigger point release work, just, pressure point release work, whatever, that's not necessarily always going to be massively helpful.
Yeah. And it's great to hear you, Jo, acknowledge too that, patients will have different rates and different paces. And, maybe some of us are coming in with a lot of medical trauma or like maybe other trauma as well into an appointment. And, it gives me, sort of great encouragement to hear that there are people out there like yourself who are taking the time and, sharing your experience and sharing your expertise as well, in sort of managing patients and helping, empower them to take on, the treatments for themselves and to take on, I suppose, the extra skill set like that we need, to help manage a chronic condition. So, Jo, we can't all go to Cork. So how would we find a good, well, we could all try. How could we find a good pelvic physiotherapist?
Well, it's going to depend on where you are as well. I mean, in Ireland, we have the Irish Society of Chartered Physiotherapists, and within that there is the pelvic health specialists. So the chartered physios in pelvic health and continence. So looking for physios who are registered with that particular specialist interest group is a good start. And also, looking for the certain qualifications. We want to make sure that we're CORU registered and all of that. So that's one place. In the UK, there's sort of the Charter Society of Physiotherapy, and you'll have your own sort of subgroup there, specialists in pelvic health. So that's the POGP group of physiotherapists. I think wherever you may be based, looking for, the regulatory body for the physiotherapists and then the subgroup within there, I think that's one place to start. However, I think there is nothing wrong with doing a bit of your own research as well and reaching out to different people. And I will often get random emails, often sent in the middle of the night at the height of somebody's pain flare, and it will be a very honest email of, I've gone to everyone, I've seen everyone, and I'm sick of being told that this can happen and that can happen and whatever else. And in truth, I think all you can do there is sort of, well, this is what I might do, and this is who I am, and here are my details, and if you want to give me a try, here I am. And I think sometimes just reaching out to different people and just sort of interacting with them, phone call, email, whatever, before you make an appointment as well.
Yeah.
I don't have a problem with that. I don't think most physios have a problem with that, because we're not just dealing with a sprained ankle here, you know? And yeah, you need to find your people.
Yeah, the trust is so important. And Jo, for anybody who is in your area, do you want to give us your website and email address? I'll pop it in the show notes as well.
Yeah, it's my clinic name is Pilates Physiotherapy Cork, and I'm sort of online. I'm on Instagram and bits and pieces like that. And yeah, I'm happy to answer any questions I can. However, I very often default to you guys because and often giving out your leaflets as well, Kathleen.
Brilliant.
So thank you for everything that you do, because that's massively helpful in the work that I do. So thank you.
Thank you. It's all part of the teamwork, you know, it really is. Jo, it has been an absolutely brilliant session. Thank you so much. And like I always learn, every time I record a podcast, I learn something else. And, you know, I've learned so much this evening, and it's broadened even my view of pelvic physiotherapy as well, which is fantastic. So thank you so much for joining us this evening.
You're very welcome. Thanks for your time.
Thank you. And thanks everybody for listening to this episode of DEARG, and we'll chat to you all again soon.